And welcome to the Dr. Bob Show. Are you bothered with tummy problems, with stomach problems? Do you have abdominal cramping pain, diarrhea, constipation, or both? Is it just, or is it irritable bowel syndrome? Or could it be due to inflammation, diseases like Crohn's disease or ulcerative colitis? We'll be answering those questions for you on the show. My guest is Dr. Raj Narayani, board-certified gastroenterologist. He'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about the different types of diabetes and how can I prevent getting a stroke. A lot of information for you. We're talking with Dr. Raj Narayani, board-certified gastroenterologist, stomach specialist, and we're talking about the differences between an irritable tummy and inflammation in the GI tract. Raj, welcome to the Dr. Bob Show.
Thank you for having me again. I appreciate it.
Talk to me about irritable bowel. Is that different than inflammation in the bowel?
They're definitely different. Irritable bowel syndrome is the most common GI disorder we are now seeing.
The most common?
Absolutely. And the reason is multifactorial. There are probably environmental and innate factors that cause irritable bowel syndrome to develop in individual patients, but estimates suggest that it occurs in about 15 to 20% of Americans.
15 to 20%. What are their symptoms?
So they're typically going to complain of abdominal pain in association with some sort of change in bowel function.
Is the pain enough to where they say, you know, something's wrong, I've got to get this taken care of? What's the pain like?
The pain can be mild or it can be severe, and it just depends on the patient. In the cases that are mild, sometimes patients will put up with the symptoms for a long time before they'll seek attention. If it's severe, of course, it may lead to an ER visit or an urgent doctor visit in order to get attention quickly so that they can get relief.
Abdominal pain, and you were about to say other symptoms before I interrupted.
So to be defined as irritable bowel syndrome, according to the criteria that have been published, the abdominal pain has to be associated with some sort of a change in bowel function or some relationship to the act of having a bowel movement.
So do they have diarrhea, constipation? What's happening?
They can actually have both. And there are three different subtypes of irritable bowel syndrome that we commonly see in practice.
Three types.
There's three types. So there's the first type, which is a diarrhea predominant type of irritable bowel syndrome. So patients are going to have abdominal pain, and they'll have frequent stools, loose stools, diarrhea type symptoms.
How many stools a day? Do the stools have a certain characteristic?
It can be variable. It can be semi-formed. It can be watery. Anything that would be classified as more than usual for the patient might be considered diarrhea.
So we've got diarrhea form. What else?
So patients can also have a constipation predominant form where they go very infrequently, they strain during a bowel movement, and in association with that, of course, having abdominal pain, that would differentiate them from just a typical constipated patient.
And the third type?
The third type is a mixed type. So there are plenty of patients who will come to you and say that they have a few days of diarrhea, and then they might shift over and have constipation for a few days, and they'll just sort of go back and forth.
So when a person comes in, they say they've got abdominal pain, they've got some constipation, they've got some diarrhea, and it's interfering with their life. How do you help them? What do you do?
Well, so the first step is to try to reassure them that in most cases irritable bowel syndrome is not a life-threatening problem. And then to help them understand that there are a few tests that can be done to help them settle to a diagnosis of irritable bowel syndrome. In young patients who have a very typical story, sometimes no tests are needed at all. And so we would typically just take a history from the patient, examine them, make sure their exam is fine, and then offer treatment in the form of either lifestyle modification, dietary maneuvers, the addition of fiber supplements sometimes will help, or in more severe cases, possibly adding pharmacological agents that might help them with their symptoms.
So what type of diet do you give them? Or just, as you said, fiber, stuff to fill the GI tract, but they're having GI tract problems. It seems sometimes that they would worry about that, or does that help them?
Well, so fiber is beneficial for many patients, especially if they have the constipation predominant form, because with irregularity and constipation, if you add some bulk to the stool, add some water to the stool, that can actually help them increase their stool frequency. For the diarrhea predominant patients, it's not always helpful, but it can be sometimes. I like to tell patients sometimes that fiber can help pull you from one extreme or the other towards the middle, towards a more regular bowel pattern. For alternators, fiber can be one of the only helpful agents. They're probably the most difficult to deal with. But fiber does have beneficial effects, and it's been studied in irritable bowel syndrome.
Predominantly diarrhea, some pharmacologic agents. What type of medicines are you talking about?
So patients have had access to antidiarrheal medicines that are over-the-counter for many, many years. They might take Imodium, they might take some of the over-the-counter liquid agents that are available for diarrhea, and those are perfectly fine for patients with mild symptoms. For patients with more severe symptoms, there have been some medicines that have been studied that bind to specific receptors in the GI tract and slow the gut's motility down so that they can go with less frequency.
So if I were having that irritable bowel and I was having diarrhea, constipation requiring medications, when do you have to do to find out? Do you have to do a scope, or is it just simple exam and history, or everybody's different?
Great question. So if a patient's in the older age group of, let's say, 45 to 60 or 70 years old, and they come in with irritable bowel symptoms, we're going to be more inclined to offer them testing up front, since the incidence of other conditions that can mimic irritable bowel syndrome that are more serious, like colon cancer, inflammatory bowel disease, can be more common. So we would tend to favor testing in those patients first before treating. In the younger patients, patients between the age of about 15 and 40, the tendency is, again, if they meet criteria and they have a typical story, to try to go ahead and treat them first before you offer testing. The only situation where that might not apply is if younger patients have any of the typical alarm features that we like to associate with the GI tract.
So you mentioned alarm factors. What are the alarm factors?
So any patients that have rectal bleeding or blood in the stool that's either visible in the commode after they've gone to the bathroom, or that's detected on one of those card kits that doctors give to patients frequently, would be considered an alarm factor. Anything that indirectly relates to blood loss, for example, anemia in their blood work, would be an example of an alarm factor.
Weight loss?
Weight loss would be considered an alarm factor because patients with irritable bowel syndrome will generally maintain their weight. It doesn't usually affect their nutrition, but in those patients who are losing weight, you'd be concerned about some other possible considerations.
So if a patient has risk factors and you have to do endoscopy, you have to do colonoscopy, is that what you have to do, or both?
In most cases, although it depends on the location of the abdominal pain and their global history to some degree. If their symptoms are in the lower abdomen and their symptoms are relieved by going to the bathroom, so they have abdominal pain, they feel the urgency to go to the bathroom, they have a bowel movement, and they feel relief, then the tendency is, again, if there are alarm factors, to offer a colonoscopy first to look at the colon. If their symptoms are centered in the upper abdomen, sometimes we will also perform an upper endoscopy to look for gastric disease, ulcers, things like that.
So if you have to do colonoscopy, what does the colon look like in somebody that has irritable bowel?
So irritable bowel syndrome is a diagnosis of exclusion. There's really not a definable lesion or finding in the colon that you can see with your eyes. And so we like to tell patients, if I'm thinking about irritable bowel syndrome in your case, I expect to see a normal colon examination. So the colon will look normal during an IBS.
So that gives the patient a lot of relief when they've got normal. Inflammatory bowel disease, is that a lot different than irritable bowel?
It's a dramatically different condition, inflammatory bowel disease.
And that's what we're going to be talking about when we come back. A dramatically different situation, inflammatory bowel disease. A lot of information. We're talking with Dr. Raj Narayani, board-certified gastroenterologist. We're talking about irritable bowel and inflammatory bowel. The irritable bowel syndrome, there's 3 different kinds, one with diarrhea, one with constipation, one with a mixture. Sometimes we need a colonoscopy to rule out things if there are things that alert us, like blood loss, anemia, weight loss. And if it's the diagnosis irritable bowel, in a way that's a relief because there are medications and there are things that we can do for that. Let's get to the inflammatory bowel. Raj, what is inflammatory bowel disease versus irritable?
So inflammatory bowel disease is distinctly different from irritable bowel syndrome. In the case of irritable bowel syndrome, when you look at the colon, you look at the bowel, it looks normal. Even if you biopsy tissue from the bowel, it looks normal. In inflammatory bowel disease, you can tell that there's damage, injury, and irritation of the gut lining when you look at it with the scope lens.
So that's the one you don't want to see, but sometimes can expect before you do it. What are some examples of the inflammatory bowel disease?
So there's two major kinds that we deal with in practice commonly. The first is ulcerative colitis. The other one is Crohn's disease.
What is ulcerative colitis like?
Ulcerative colitis is a condition where inflammation and ulceration forms in the colon. It usually starts down at the very bottom in the rectum and works its way up the colon, and typically is limited to the colon only, which is a good thing. Crohn's disease, on the other hand, can affect anything from the mouth down to the very bottom, and so you can have any part of your GI tract affected by Crohn's disease.
If Crohn's disease is involving the mouth or the esophagus, the stomach, do they still have colon problems and small intestine problems, or it can be isolated?
It can be isolated in some cases, but
Wow.
that's a fairly rare presentation of Crohn's disease. Most patients with Crohn's disease are going to have involvement of the end of their small intestine and the right side of their colon. That probably comprises about 70% of Crohn's patients.
So what are their symptoms? Let's flip to Crohn's right here. What are their symptoms?
So Crohn's patients will typically come to you and complain of abdominal pain, diarrhea, sometimes some blood in the stool, and in many cases they'll have nutritional consequences, including weight loss.
So they have weight loss, nutritional consequences. They just get frail, they wither away. Why is that?
Well, in many cases with the inflammation where it's located in the small intestine, large intestine, they'll lose a lot of their macronutrients in the stool because they're not absorbing them as a result of that inflammation. Inflammation in general in the GI tract is also catabolic, so it'll participate in the breakdown of some of your proteins.
So it's not a fun disease to have. Is there treatment for it?
There's good treatment now available for both Crohn's disease and ulcerative colitis. You'll see ads on TV all the time for all these newfangled agents that help suppress the immune system so that the bowel can calm down and reestablish good health and then normal nutrition again as well.
Let's flip over again to ulcerative colitis. Predominantly just in the colon, starts in the rectum and then works its way around. What does that look like when you do colonoscopy? What's the biopsy look like?
If you do an examination with the colonoscopy, what you'll typically see is redness in the colon. It'll almost have a purplish hue to it, and it'll look diffusely inflamed. So the entire colon from start to finish of your exam will look inflamed. It will bleed easily if you move the scope against the lining. The biopsy will typically show you a significantly increased number of inflammatory cells in the tissue than you're used to seeing in a healthy colon.
The treatment that we have now is so different than we had when I started in practice. What is the treatment for ulcerative colitis?
Ulcerative colitis treatment depends a little bit upon the severity of the disease. So if you have mild disease, we still use some of the agents we used back in the 60s and 70s. They're basically medicines that are anti-inflammatories. They're called aminosalicylates, and they work quite well, and they don't really involve a significant level of immune suppression. They don't really.
So what's an example of an aminosalicylate?
So a common one that's used is sulfasalazine. Azicol is another one. These are compounds that have been around for a very long time, and many ulcerative colitis patients still take them and enjoy remission from them.
So they can get into remission with that. Does that mean the disease is permanently out of there if it's mild and they take the medicine and go into remission, or chances are it'll come back, or you don't know?
Well, so if a remission is established, typically the patient will say, my symptoms are much better. You might look at their colon with another colonoscopy, follow up and see that their colon looks a lot healthier. It may not be completely normal, but it's pretty close. The problem with remission, though, is it is not permanent, and there are plenty of opportunities for patients over the course of the lifetime of their disease to flare again and develop a recurrence of the disease, a recurrence of the inflammation.
Is there anything that you can tell the patient to do with ulcerative colitis that takes medications, that goes into remission to keep from it coming back?
Absolutely. So the most important factor is for them to stay on their medication at the dose that's recommended.
Okay.
If they can do that, they have the best chance of staying in remission.
So they're going to take the aminosalicylates for a long time on that. Any bad side effects with those?
Usually not. There's very rare instances where they can cause some kidney problems, but generally they're very safe medicines.
So let's go back now to Crohn's disease, because that involves more of the GI tract. Ulcerative colitis, just mainly the colon. So treatment of Crohn's disease, how does it differ from ulcerative colitis?
The aminosalicylate medications that we talked about earlier, which have traditionally been used for mild or moderate Crohn's, don't seem to work quite as well because they're delivered in the colon and they work topically. Many cases of Crohn's disease involve the end of the small intestine or upper parts of the small intestine, and so in many of those cases, the disease is located farther up from where the drug is actually delivered. So a lot of the newer medicines that are available for Crohn's are systemic medications. They're medicines that are delivered by injection or by IV form so that they can circulate in the blood, come back to the GI tract, and work along the whole length of the gut.
What's the name of some of those medicines, and give me a little science on how those work?
So an example of some of these newer agents, they're called biologic agents, basically. Remicade is an example that you'll see ads for TV on. Humira is another one. These are medicines that are synthesized in a lab. They are basically antibodies against a molecule that is seen in high quantities in the inflammation of these two diseases. So,
isn't it wonderful that we have those? So they're anti-tumor necrosis factor, if I remember the words, like that. And so you've got antibodies against those. Are they really effective? They really do a good job for patients?
They certainly do, and they've been studied very well also. There are lots and lots of patients now that have been studied and treated with these anti-tumor necrosis factor medications. And that goes beyond even the inflammatory bowel arena. Patients with rheumatoid arthritis and other autoimmune diseases have been treated with these medicines with success. And so we're thrilled that we have them because they work so well. There are instances sometimes where patients will take them, they might lose effect, they might have to switch to a different one, but on the whole, they work very well.
I think that's so exciting that you have this now to offer patients. Something that really was more difficult to treat in the past, and now you can go into remission, you can keep it under control, both ulcerative colitis and Crohn's disease. So if somebody has severe ulcerative colitis, sometimes do they have to take out part of the colon or the whole colon?
In cases with ulcerative colitis where medicines stop working, or in cases where patients become so sick that they end up in the hospital and their colon stops working, there are instances where patients will have to have a colectomy. When surgery is done for ulcerative colitis, the whole colon is usually removed, because if you don't do that, then the remaining colon that you leave behind will usually become inflamed after surgery. So a total colectomy is typically performed for ulcerative colitis patients.
I've seen several patients that have had total colectomy, and they do really well because of the excellent treatment you all give. I wish we had more time to talk on that part. So irritable bowel, that's the best diagnosis. Inflammatory bowel, we've got great treatment for Crohn's disease. We've got great treatment for ulcerative colitis, much better in the past. Raj Narayani, thank you for giving us the assurance that there's things that we can do for serious GI problems. You're a great teacher.
It's a pleasure, and I thank you for letting me come again.
If you've got GI problems, if you've got diarrhea, constipation, you're not sure what it's due to, be sure you have it adequately evaluated. And now you'll want to stay tuned, because we're going to be talking about different types of diabetes and how to prevent a stroke. It can be done. A lot of information for you. Hello, I'm Dr. Bob Overholt, here to encourage you and your family to get out and play in our Knoxville area parks. Knoxville has dozens of parks and more than 85 miles of trails. There are picnic shelters, ball fields, tennis courts, and disc golf courses, dog parks, fishing ponds, and skateboard parks, trails for hiking and mountain biking, boat rentals, you name it, Knoxville has it. To find a park or greenway near you, visit OutdoorKnoxville.com. And get out and play, it's good for your health. I want to thank Dr. Raj Narayani. Wonderful discussion, the difference irritable bowel, inflammatory bowel. Thanks, Dr. Narayani. Now, questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, my doctor says I have diabetes, but he didn't say I needed insulin. I'm confused. There's two types of diabetes. There's type 1, that's usually insulin requiring. What happens is the pancreas doesn't put out enough insulin. We need insulin to help food go, glucose, sugar, go into the cells, and the cells to get energy from glucose. So if there's not enough insulin, insulin can't guide blood sugar into the cells. So that's type 1 diabetes, where you have to inject the insulin because the body won't make it. Type 2 diabetes is entirely different. There's an insulin resistance. The body makes insulin, but the body is resistant to it, and so the insulin doesn't work. And so when the insulin doesn't work, there's a couple things that happen to the body, makes us really, really hungry. When there's a lot of insulin in the bloodstream that's not working because there's insulin resistance, then we get hungry, we get obesity, and then we have to use medicines that can help the blood sugar get into the cells. That's type 2 diabetes. Both are so important because whether you've got type 1 requiring insulin or type 2 that you can use diet and lifestyle changes, they both have high incidence of elevated cholesterol, of hypertension, of poor blood supply, of blindness, of chronic kidney failure, of heart disease. So when you've got diabetes, it's a wake-up call, type 1 or type 2, that you've got to be really, really strict on following a proper diet, of being more and more active, of having a plan with you and your doctor that you can follow, that you can keep your blood sugar normal. Now, if we can keep the blood sugar normal, then there are chances that you may not get hardening of the arteries, that you may not have to have an amputation, that you may not get blind. So pay attention to diabetes. If you've got type 2, don't throw that to the wayside, because if you do, you may have problems later on. Sometimes it's hard to say, well, that won't happen to me. Sure can with diabetes, high incidence. It involves the small vessels that nourish the eyes and the muscles and the kidneys and the heart. So pay attention to diabetes. Work that out with your doctor. You'll do well. Question number 2, Dr. Bob, what should I do to prevent a stroke? I have a strong family history of stroke. Good questions. Look at your family history. We're now living longer, so the family history is more important than it used to be. And so if a lot of people had strokes, then you have to think about what causes strokes. It's usually hardening of the arteries. It's usually cholesterol deposition into the blood vessels that go to the brain, or it could be to a heart arrhythmia called atrial fibrillation. If you've got atrial fibrillation, then 25% of strokes are due to a little blood clot that goes from the heart and it goes up into the brain. So if you've got an irregular heartbeat, atrial fibrillation, you need to talk to your doctor to see if you should be on a blood thinner to keep a blood clot from forming. The other things that you need to do is to keep hardening of the arteries from occurring. Since there's a family history of stroke, what can you do to keep that from happening to you? Eating properly, eating good foods, fruit, fiber, vegetables, Mediterranean diet, less beef, less red meat, less fried fatty foods, less bad foods. Google it, find the Mediterranean diet, use that diet. Exercise. When you exercise, it will help you prevent strokes because it's the only way to get the good cholesterol that will pull, the good cholesterol will pull cholesterol out of plaques. You'll have less hypertension. You'll have less problems if you begin to exercise. So know what your cholesterol is. If your cholesterol is elevated, then you need to talk to your doctor about how to get it down. It may be medications or it may be lifestyle changes. So in the Dr. Bob Show, we always talk about exercise, sleeping right, eating properly, 7.5 hours sleep and laughter in your life. We'll be talking about those in a minute. They're so important to preventing stroke. So remember, if you have parents with stroke, know that you need to exercise and you need to eat properly. You need to know if you have hardening of the arteries or high blood pressure. If you've got high blood pressure, it can be treated. That's all the time we have for this show. Let's re-go the 4 things that we talk about all the time on the Dr. Bob Show. Number 1, exercise. Reduces stress, makes you feel better, get a runner's high. You're happier if you exercise well. It decreases blood pressure. It helps us lose that weight. What more do we want than regular exercise? Get your tennis shoes, get out there and walk. Eat properly. Start the breakfast with fruits and with fiber. Make lunch maybe your biggest meal and supper your littlest meal. Eat fish like salmon at least once a week, maybe twice a week, as omega-3s. That will help your heart. It will help you be better. 7.5 hours sleep, wow. That's so important for you to feel better, for you to perform better, to you be happy, for people around you to be happy, you know, and to be able to not get behind in your work. Get that 7.5 hours sleep. And most of all, we like that laughter in your life. Know that if you laugh a lot, people around you will laugh, you'll be healthy, and you'll live longer.